This is the USAID Infectious Disease Detection and Surveillance Project, or IDDS. This webinar is being recorded. The recording will be made available later in the week to attendees and those who registered. Questions can be posed by typing into the question interface on this platform. Questions will be addressed in the Q&A section at the end of this program. Fact sheets are available via the Handouts button. And now to start our program, here's our moderator.
Hello all. We welcome all of you for this webinar, which is about improving bacteriological confirmations of tuberculosis in children. I'm Kayuri Arvind Bhanushali, TB survivor and a TB activist from India. Today, I will be moderating this session for you. Without any further delay, let me introduce our subject matter experts. Andwele Mawan-Sasu. She's Senior Infectious Disease Technical Advisor, IDDS. Today, Andwele will provide us with opening remarks for the upcoming session. Charlotte Colvin. She is Senior Technical Advisor, U.S. Agency for International Development. Charlotte will provide context on pediatric tuberculosis. Duong Ngoc Quang. He's Vietnam TB lead IDDS. Quang will share experiences from Vietnam. Winnie Moanza. She is Laboratory Advisor, National Tuberculosis and Leprosy Control Program. Winnie will share experiences from Zambia. And now, I would like to hand over the session to Andwele Mawan-Sasu.
Thank you, Kayuri, for the warm welcome, and good day, everybody. In 2018, the global health community at the United Nations High-Level Meeting on Tuberculosis set forth bold targets for detecting and reducing TB in children. And one of the targets was to treat 3.5 million children with TB by 2022. However, as of 2020, we as a global community only achieved 41% of that 5-year diagnosis and notification targets. The COVID-19 pandemic has significantly impacted children and adolescents with TB and those at risk of TB. Due to COVID-19 disruptions, there was 24% decrease in TB notification among children between 2019 and 2020. The impact of the pandemic is also seen in the high number of deaths reported in 2020. With continued threat of COVID-19 in 2021, the 5-year target is almost certainly out of reach. Detecting TB in children is challenging due to many reasons, one of them being non-specific nature of tuberculosis in children, especially those under the age of 5. We'll hear more about these challenges in the following presentations. To catch up with the UN high-level meetings targets on TB, we need to aggressively manage tuberculosis in children and adolescents while recognizing their unique characteristics and need. This webinar follows the WHO guidelines on tuberculosis, which recommends stool testing as the initial test for children with presumptive TB. Today, the IDDS project and USAID are proud to share learnings from 2 countries that have begun using stool to test pulmonary tuberculosis in children. It is our hope that the lessons learned from these 2 countries' experiences can inform others as they plan to introduce this technique. The IDDS project is a 5-year USAID contract, and part of our mandate is to decentralize access to quality TB diagnostic services to the lowest quality of care. IDDS collaborates with others to support the use of stool samples per WHO guideline, provide tools and training for adoptions. I'd like to thank all of our speakers for sharing their expertise and experiences today, and thank all of you for joining us today. Our goal today is to outline the procedures for testing, share experiences and lessons learned, and also offer recommendations. And the agenda will follow as shown ahead of you, stool-based testing in context, and we hear experiences from Vietnam and Zambia, and we have an opportunity for discussions and questions and answers. And now it's my pleasure to welcome Charlotte Colvin, our first speaker, who would help us place stool-based testing in pediatrics in context. So welcome, Charlotte.
Thank you so much, Andwele, and thank you to our IDDS colleagues for organizing this webinar. I'm very happy to be here. Next slide, please. So just to set this in context, this slide is from WHO. It includes summary data from the 2021 Global TB Report and shows that just over 1 million children developed TB in 2020, with almost half of those under the age of 5 years old. And about 226,000 TB deaths occurred among children 0 to 14 in 2020, and notably, 96% of those deaths occurred in children who did not access TB treatment at all. So as you can see, the need for really high quality diagnosis is pretty dire. Next slide. This slide also from WHO just shows the differences in case detection between very young children and older adolescents and adults. So you can see that among the younger children, we have a case detection gap of 72.5%. That means that only about 27.5% of the estimated cases are actually diagnosed and notified to national TB programs, which also helps to understand this context for the need for improved diagnosis for children. Next slide. So this is just to summarize what Andwele was referring to earlier, which is the very specific challenges to pediatric TB diagnosis. So children often do not produce sputum via cough, especially very young children under 5 years old. And we often have to rely on invasive procedures to obtain a specimen for bacteriological testing, such as gastric aspiration or nasopharyngeal aspiration. And these procedures are first quite unpleasant for the child. Often parents are not consenting to these procedures, but also the capacity to perform these procedures is often limited to higher level healthcare facilities. Also, even when a specimen is available, children will often have paucibacillary disease. So even if we can get a sample, the bacteriological test may produce a negative result. However, sputum can be found in stool, and a molecular diagnostic test can be used to detect TB. So this is a nice option that many of our colleagues who with an interest in child and adolescent TB have been working on for a number of years since the GeneXpert technology became available. Next slide. So USAID support for stool-based TB diagnosis is based in a number of updated WHO recommendations for the management of TB among children and other relevant guidelines that have been published since January of 2020. The guideline in January of 2020 on diagnosis of TB included stool as a recommended stool as a appropriate sample for diagnosing TB among children with expert. And so we began to work with a couple of consultants, Dr. Evelyn Klinkenberg and Dr. Lisa Adams, to produce some interim guidelines on pediatric TB, which have been disseminated to missions and partners and our global fund advisors. And we called these interim guidelines in September of 2020 because we knew that the WHO guidelines, which were just the WHO guidelines for the management of TB among children, were forthcoming. They were just published this past World TB Day. And so we wanted to have at least some resource available to support our partners and missions in the interim. And I want to just say that even though this webinar is going to focus on stool-based testing, which is really important and something we're very happy and proud to be supporting, we really do advocate for a very comprehensive approach to strengthening TB diagnosis for children, because we know that even under the best of circumstances, we still need to rely on clinical assessment often to make that diagnosis. And this is one of the reasons that we've involved Dr. Lisa Adams in this effort to bring that clinical expertise to the activity. Next slide. So in terms of implementing this, we've been collaborating with USAID missions, national TB programs, our bilateral funding mechanisms and local organizations network program, and the TB implementation framework agreement, a variety of mechanisms to support this work. And we also work really closely in each country with our global fund advisors, who are really instrumental in helping us move this along with national TB programs. We're investing in capacity building for the simple one-step stool processing method, which was developed by KNCB in Ethiopia, and the Supranational Reference Laboratory in Uganda. We're working with both of these organizations to try and build capacity to process the stool and to make sure that we have expertise available locally to train others in this process. Currently, we are supporting the piloting and rollout of stool-based TB diagnosis in the Democratic Republic of the Congo, Kenya, Malawi, Ukraine, Vietnam, and Zambia. And we're currently working with colleagues in Burma, Mozambique, the Philippines, and South Africa on some early planning activities. We've also had some long-time implementation going on in Nigeria and are really looking for other opportunities to support this work. Next slide. This slide is meant to summarize USAID's approach in terms of how we think about phasing in, piloting and phasing in and scaling up the use of stool-based TB diagnosis for children. We like to think of this process in three general scenarios. So for example, in phase 1, which we call the rapid validation phase, is used in countries where there's a very clear need to provide data for this to support the use of stool-based testing as an alternative to sputum testing. In some countries, they've kind of they've sort of passed over this validation phase and gone straight to looking at laboratory practices and scale up. But in other countries, there's a real need for country-specific data to validate the process. And so we've supported this type of work, for example, in Zambia, which you'll hear more about later. And you can take a look at these more in a more detailed fashion later, but it's just a way that we think about organizing and thinking about how we can best respond to the needs of specific TB programs as they go through the process of piloting and scaling up stool-based diagnosis. Next slide. Thank you so much. I'm very much looking forward to hearing from our colleagues from Zambia and Vietnam and to the questions and answers. Over to you, Kiri.
Thank you, Charlotte, for setting the webinar in context. And now here's the next speaker, Dr. Kung, to speak about experiences from Vietnam. Welcome, Dr. Kung.
Thank you, Kiori, and thank you, Charlotte, for your comprehensive introduction of the stool-based diagnosis program. So I'm willing and very happy to be here to present our experience on Vietnamese TB program on IDDS for especially for the stool TB diagnosis. Next slide, please. So Vietnam estimated about 10,000 to 20,000 of new pediatric TB cases in 2020, but only like less than 20%, like less than 1,400 cases in children were reported that year. So we have a lot of challenges in diagnosis for TB in children. As Charles already mentioned, there's some non-specific symptoms for the disease, and also very difficult to collect the viable sputum and gastric aspirate specimen in children. And a high quality X-ray also difficult to obtain in the children less than 5, and interpreting of X-ray also not always available. So Vietnam incorporated gene experts at initial diagnostic testing for TB in children using the respiratory and non-respiratory specimen into national guidelines already. So our objective is to improve the diagnosis of TB in children from 0 to less than 14 years old in health facility in 5 provinces, and also to expand the gene expert testing technique on stool specimen for pediatric TB diagnosis. Next slide. So we follow the NTP algorithm for screening children for TB diagnosis, but there are also some actual practices for collection of the stool specimen that we would like to share. Normally for the children from 0 to 4 years old, at the routine examination at health facility, we screen them using the presumptive TB symptoms and abnormal chest X-ray. But for some active case finding like ACF in the community, where we do not have time, enough time, or some difficult to contact with the patient. So every children have the household contact with a pulmonary TB patient, we screen them. And for the 5 to 14 years old children, we also screen them with a presumptive TB symptom and abnormal chest X-ray at the health facility. If they cannot produce the sputum specimen, so we collect the stool specimen, especially for the ICF campaign. We also prioritize the household contact, the patient with household contact with the TB patient, and also have the presumptive TB symptoms. Next slide, please. So this is the service flowchart that we support the NTP for the TB program. So we train the whole service healthcare members, especially for the doctor. They were trained on identify the children with presumptive TB, especially as ACF campaign, or even in the routine healthcare health examination. And they will was also trained on consulting the parents on TB diagnostic testing option for children. And then healthcare worker will guide the parents on how to collect samples on TB diagnostic testing, both for sputum or stool sample. And the parents or the guardians of the children will collect the stool sample at the health facility or at home and send the specimen to the health facility. So the healthcare worker were trained to package and transport the stool specimen to gene expert testing laboratories. And the lab technician were trained on, how to receive the sample, identify if the sample is good enough for the gene expert testing, and perform gene expert testing using the stool sample, and also generate and share the result with the healthcare worker and parents. Next slide. So as you can see on the screen, the number the number of the children that we screened from May to December of 2021, it's actually, this number is not so many because of the COVID lockdown at that time, but you can see that the most of the children was from 0 to 4 years old, and we can barely reach the patient at the routine examination at the health facility because of the hospital were locked down and they cannot come to the hospital. So we can reach them in the ICF campaign in the community instead. So more than 95% of the children that we screen in the ICF campaign. Next slide, please. So based on the results that we find in our activity, we can see some fact and made some recommendation and next step for the NTP program. The fact number 1 is like the stool-based expert testing account for like nearly 40% of all pediatric TB diagnostic testing in 2021. So we recommend that continue to prioritize stool specimen collection in children, especially the children like less than 4 years old, of less than 5 years old, and because it is very difficult to take the sputum from them. And we keep facilitate the guidance from NTP to provinces and the partner. Number 2 is the detection rate in stool-based testing was low at like 1.1%. As I mentioned earlier, is because of the COVID lockdown, so we cannot, get many patients as we expected. We recommend that we keep reviewing the criteria for collection of stool specimen, especially for the clinical symptom and also the abnormal chest X-ray required. And we keep facilitate guidance from NTP to provinces and partner to increase the detection rate, the notification rate. Number 3 is like only 5% of the stool specimen were taken during the routine health examination, and more than 95 were taken during ACF campaign. As I mentioned earlier, so we unfortunately that these days the pandemic, the number of the COVID cases is going down really quick, and we can travel again, and we try to increase the facility-based stool specimen in the healthcare facility to increase the number of the children with pediatric TB, and we keep facilitating with NTP to strengthen the pediatric TB diagnosis in the public and private mixed health facilities. Number 4 is only 2 out of 8 district level laboratory have implemented stool-based gene testing. As I mentioned, the hospital was locked down, so from now on we try to strengthen the implementation of stool-based gene testing at the district level. And during the pandemic, we try to organize the virtual technical assistant to the district lab. But now we can like travel again, and we can go to the district gene expert lab to provide them with the hands-on training, and hopefully that they can actively join to the network to increase the TB notification in children. The last but not least, the overall error rate across the 5 provinces were like nearly 8%. But from time to time, it keeps going down, and the sites show the better result in their practices. So we recommend that we continue to provide the technical support from central level to reduce the error rate in stool-based gene expert testing. And if we cannot go to the lab to organize the hands-on training, so we can organize the virtual TA to gene expert lab. So those are the activities that we implement in Vietnam. And thank you very much for listening, and I'm happy to answer any question. Back to you, Kiori.
Thank you, Dr. Quang, for sharing your insights from Vietnam. And now here's our next speaker, Winnie Mwanza, with experience from Zambia. Welcome, Winnie.
Thank you, Kiori, and thank you again, IDDS, for this opportunity for Zambia to share our experiences with introduction of use of stool for diagnosis of TB in children. Next slide, please. So in 2020, Zambia notified 2,759 childhood TB cases, and this represented 6.8% of all notifications. We have, as a country, seen an increase in case detection, specifically in the age group 0 to 4. But however, despite this increase, we are still not meeting our benchmark of 11% that we expect to be childhood TB cases among all forms of TB. So efforts to improve childhood TB case detection remain a priority for the National TB Program. And what we saw was that use of stool is one strategy that we can adopt to help us improve case detection in children. Next slide, please. Yeah, so early in 2020, we embarked on the process to introduce use of stool in the country. And just to give a perspective on our diagnostic network, we have 262 gene expert testing sites in the country, and 52% of those are at health center level. And our health center levels are characterized by limited to no capacity to perform gastric lavage. Additionally, laboratories at this level of healthcare also have the lowest level of biosafety standard. And so we considered the fact that we needed to implement use of stool at all levels of healthcare, at all sites that have a gene expert on site. And so this really influenced how we were going to pick on or make choice of a stool processing method that would work at all sites that have a gene expert. And the simple one-step method developed by KNCV met this criteria because it is as simple to perform as it is for sputum processing for GeneXpert testing. Next slide, please. So the first step that we took was to carry out a validation of stool testing on the GeneXpert using the SOS method. And our objective was really to measure the sensitivity and specificity of Stool-expert compared to the specimen types that we were using routinely. This is sputum for children that are able to expectorate and gastric aspirates in those children that are not able to expectorate. So the approach that we took was then to do a head-to-head comparison of stool GeneXpert compared to sputum or gastric aspirate expert. Next slide. Thank you. We approached our validation in two phases. In the first phase, we also included adults. We had adults that had bacteriologically confirmed TB. We also had presumptive adults as well as presumptive TB children. And then in our next phase, we continued the parallel testing of gastric aspirates and stool in children alone, just so that we can increase on the number of children to include in this evaluation. And what we saw was that Stool-expert had an accuracy above 95%. We saw a sensitivity of 86% when adults were included, and 75% in children alone. The specificity was 100% across the board. We also saw that Stool-expert had a very good discriminative power to distinguish children who had TB from children that did not have TB in a clinical setting. We were able to validate this using the ROC analysis. And within this validation, we were able to detect one adult who had rifampicin-resistant TB, and the resistance was detected both on sputum and on stool. Next slide, please. Next slide. So after a successful validation, we went ahead as a country to scale up use of stool at all GeneXpert testing sites. And so what we did was to develop training slides, the test algorithm, as well as laboratory procedures for processing of stool. We constituted teams to cover all 10 provinces, and we were able to achieve this with support from USAID through its implementing partners, as well as the Global Fund. And we did form teams that constituted 2 lab staff and 2 pediatricians to go to each province. And by the end of 2020, we had 74% of our GeneXpert sites trained on stool testing. And with introduction of use of stool, we also implemented a monitoring system. And the aim was for us to be able to make a comparative evaluation of the contribution that stool was making to the detection of TB cases in children. Next slide. Yeah, so what did we see? We did see early impact with introduction of use of stool. We saw that within the first 6 months of implementing use of stool, 77% of pediatric specimens reaching the lab were actually stool specimens. And we saw that stool contributed 84% of bacteriologically confirmed childhood TB cases. Next slide. And at the end of 2021, we did see as a country significant gains, overall gains in childhood TB notifications. We saw sharp increases both in case detection for childhood TB, as well as in bacteriological confirmation of TB in children. And this sharp increase did coincide with the introduction of use of stool. But however, I must mention that the approach that we took when we were introducing use of stool was a holistic one that really aimed at optimizing the diagnostic algorithm that was inclusive of all modalities that are important to making a diagnosis of TB in children. So we still placed emphasis on clinical diagnosis. We still placed emphasis on use of gastric aspirates, but also introduced stool to be used as an alternative specimen for gene expert testing where a gastric aspirate could not be collected, and where skills for collecting gastric aspirates were not available. So the gains that we see really attributed to a more strengthened algorithm that is inclusive of all modalities for detecting TB in children. Next slide, please. Yeah, so what are some of the lessons that we have learned? Here we have just highlighted a few lessons that we have learned from introduction of stool, expert testing. We have seen, firstly, that detection rate on stool samples is as good as it is on gastric lavage. In our setting, specifically on the data that we are presenting here, we actually saw a slightly higher detection rate on stool compared to gastric aspirates. Secondly, we have also learned that the acceptability for the SOS stool processing method is very high among our lab staff. We have also seen that use of stool can increase the number of children being bacteriologically investigated for TB, and this is a very good indicator both for increasing the proportion of children that are being bacteriologically confirmed, but also for detection of drug-resistant TB in children. And another lesson that we learned was that targeting diagnostic centers only for the initial trainings can delay uptake at non-diagnostic centers. And this point is actually what has influenced our next steps, because we have noticed a gap that uptake is slow at non-diagnostic centers and treatment centers in terms of them initiating use of stool. And so what we recommend to countries that are planning to embark on this introduction of use of stool is that they must approach it holistically. They must involve the entire network, including just treatment centers and non-diagnostic centers, in terms of disseminating the information on use of stool. The orientations and trainings should target the entire network. So our next steps, which are really aimed for us to close in the gap and to optimize use of stool at a national level, we have requested provinces to present progress made with stool gene expert implementation in their provinces at a planned data review meeting that we have planned. And we are hoping that these approaches, the presentations that we are going to receive will allow us to identify specific gaps that we need to address for us to optimize use of stool in the country. We've also planned to offer targeted on-site mentorship on stool testing through collaborative efforts by the NTOP and partners. We are also developing and we are planning to develop and to disseminate job aids on stool collection, packaging, and handling for referral to expert sites. And for us, we are lucky that the method that we adopted has now been recommended by WHO as a standardized method that can be used. So we are not redoing our SOPs. We are just going ahead to strengthen it and disseminate further information on how we can optimize the entire process. We are also planning now to include stool expert testing indicators on routine supervision and external quality assessment visits, just so that we continue strengthening use of stool in the network for diagnosis of TB in children. Next slide, please. Thank you very much. These are just a few pictures that we took during the orientations and training for use of stool. And thank you, IDDS, again, and back to you, Kiori.
Thank you, Winnie, for sharing your insights from Zambia. We will now enter the final part of our program with question and answers. I'm waiting for questions. Meanwhile, can I ask two questions which I received from the attendees?
Go ahead.
Yeah, thank you. First question is for Dr. Kong. As they are asking that as stool-based diagnosis has expanded in your countries, have you adjusted your orders for expert cartridge? Do you have any advice on how other countries should approach changes to the forecasting and supply of cartridge? This is for Dr. Kung.
Thank you, Kiori. Yeah, the question is very important and very interesting. You know, for the not only for the IDDS but also for the national TB program in country, because we have to calculate and take care of everything before the activity implemented in the country. We have to make sure that we have enough the intragenous for testing. Luckily in Vietnam, we have NTP to take care of distributing the cartridge to the provinces. But as we implement our activity, we also have to discuss with NTP in advance to see if that province have enough the cartridge to conduct the the testing. So we plan the and we estimate the number of the cartridge that we have to use at each province, and then we discuss with NTP to make sure that those cartridge are available at the province before we implement the activity. And during the training, we also asking the laboratory and also make sure that they have enough the cartridge, and also they be trained on how to use and interpret the results during the implementation processes. So in short, we have to make sure that we have enough cartridge in country or in the province that we will implement the activity, and very important to work closely with NTP program or any entity who take care of the logistics and the supply chain in the country to make sure that they have enough cartridge at the lab. Thank you.
Thank you very much for your answer. I've got one more question, and that is for Winnie. Winnie, the question is, as stool-based diagnosis become more available, what role do gastric aspirates play in the diagnostic algorithm? For example, where it is possible to perform the procedures, is it still the first test for children with suspected TB, or do you think stool will eventually replace gastric aspirates?
Thank you, Kiori. Yes, so like I mentioned in my presentation, the approach that we took when we developed the algorithm, we really placed the gastric aspirates still priority where collection is available. And it is really too soon for us to make decisions of replacing gastric aspirates with the coming of use of stool. So my response is that gastric aspirate still has a very important role to play. With children, diagnosis is very difficult, as even Charlotte has alluded to, and so we need to use all modalities that are available to be able to make a diagnosis. So where we have skills, where it is acceptable to the caregiver, the healthcare worker, where it is acceptable to use gastric lavage, we should continue using gastric lavage and still place stool as an alternative specimen to use where a gastric aspirate is not possible to be collected. Over.
Thank you very much for your answer. Are there any other questions from the audience? Here is the question. How efficient is Stool Expert Ultra in determining TB in children? We'll take this. Charlotte, will you take this?
Sure, I can give it a shot, and then I might ask Winnie and Kwong to also weigh in. So if I understand the question, is it that Ultra is compared to the MTB RIF cartridge, or just Stool Expert in general? If it's the former, I do think that Ultra is with the WHO recommendation to use Ultra that came out in at the end of March as part of their recommendations. I think that's a signal that Ultra does have superior sensitivity to detect TB among children. And so we are, as USAID, wherever possible, we generally are asking countries that we're working with to use Ultra as opposed to the Expert MTB RIF cartridge. However, the reality is that not every country has completely transitioned to the Ultra cartridge. And so, you know, in some countries we have Ultra only, in some countries we have a little bit of a mix. In some places, in some countries, I think we're seeing a transition, and Winnie may be able to speak to this in Zambia, because they started so much earlier than other countries. The initial validation was being done on MTB RIF, and now the rollout is being done increasingly with Ultra. So I hope that answers the question, but the big picture is we are trying to really encourage the use of Ultra wherever possible, especially since so many countries are transitioning to Ultra in the first place. But we don't want Ultra, the lack of having Ultra, to be a barrier. We still think that, you know, if the country is still transitioning, it's better to go ahead and start with Expert MTB RIF, where you have it, and get the activities up and running, and then eventually transition to Ultra as much as possible. I don't know, Winnie and Kwong, would you like to comment on that as well?
Yes, thank you, Charlotte. I can comment on that. When we did our validation, actually, we did have a comparison of Ultra as well as MTB RIF within that validation. And so our detailed report will have information on that. And I must say that we didn't see any differences in the performance or expert results on both MTB RIF as well as Ultra. So there was no difference. All the specimens that were positive on both the Ultra and the MTBF. So I wouldn't worry about not being able to detect TB with either of the cartridges. But like Charlotte has said, the recommendation from WHO has come to for Ultra, and we should use Ultra as we transition, but nothing really should stop countries from using MTB RIF on stool as well. Over.
There is one more question for Winnie. What are some quality indicators for stool expert testing? What was used in Zambia? This is for you.
Thank you. So the similar indicators that we do for sputum, we are monitoring as well for use of stool. And of importance is the error rate. You know, with use of stool, of course, the particles that can cause error rate more likely to happen than on a sputum. So we are monitoring error rate, and we have no concerns currently with error rate. It is performing just as well as it is for sputum. We are also monitoring positivity rates just the same way we do for sputum. So those are the quality indicators, just the numbers that we are testing, the error rates, the positivity rates, and the rate of invalid or indeterminate results that we are getting. So we've just sort of replicated the same quality indicators that we monitor for sputum, and we are monitoring that for stool as well. Over.
Now this question is for Vinny and Kong both. What is the acceptability of stool diagnosis with parents and healthcare worker? Do they trust the results?
Well, for the acceptability of stool diagnosis with parents and healthcare worker, because when we train them, we also show them, what we have done and what other country and also the WHO recommendation for this test. So, and because for the small children, the young children, it is very difficult for taking sample like sputum sample or gastric aspirates from them. So parents are very, they're willing to collect the stool sample, and because it's more convenient for them, it's just about, they have to come back to the healthcare facility to submit the specimen. So it takes a little bit more time for them, but it is more convenient for them. So it is very well accepted both by parents and the healthcare worker. Over to you.
Thank you. It is a similar situation in Zambia as well. The results are well accepted, and even submission of stool is well accepted, even among healthcare workers. What we did is we really explained the rationale that it's actually the same sputum that gets swallowed up by these children, and it gets passed through stool. So at the end of the day, it's like the same specimen that we are testing. And so with this understanding by our healthcare workers, they are then able to explain even to parents who would be surprised to say, how can you be testing TB from a stool specimen? So our clinical staff are able to explain the rationale behind the use of stool, that it really comes from swallowing up of the sputum and then it gets passed out. So acceptability is good in our experience. Over.
And now the question is for Anvele. Can you describe the stool SOS processing method?
Thank you. I'm not sure if I'll be able to do justice to describe the method properly as at KNCB folks, but what I would say it's called simple one-step method because it does not require multiple steps to processing stools vis-a-vis the other method that has been tested before. I hope that suffices the answer. Thank you.
This question is for Charoler. Can stool be used for treatment monitoring?
Thanks, Kayuri. The answer to that question is no. Right now, there is no recommendation to use stool-based testing for treatment monitoring among children. I think in general, expert is not used to monitor treatment among adults either. And right now, the WHO, I believe, is recommending clinical assessment, ongoing clinical assessment, and looking for clinical improvement to assess the outcome or the ongoing effects of treatment monitoring. Thanks.
This one is for Dr. Kong. What measures are needed for transport of stool samples?
Well, first of all, we have to treat that as another infectious sample. So we train and recommend it, and we also provided some supplies for the healthcare worker and the parents to collect the stool sample. First, they have to be properly put in the content, like in the container, and then they have to transfer they have to transport the specimen as soon as possible to the health facility, because you know that in the stool sample it is not the impurity specimen, so it can be changed during the time. So we have to transport it as soon as possible to the healthcare facility and ensure that you have properly packaged, like triple layer packages as normal infectious disease specimen. Back to you, Kayuri.
There is one more question for all. Should gastric aspirate continue to be collected? Where do you recommend the use of stool versus gastric aspirate? This is for all.
I can start with that and then turn it over again to Winnie and Kwang, since they're actually doing a lot more of this than I am. I think that our position is similar to what Winnie described. I think for the time being, where gastric aspirate is available and you have a trained provider who's able to perform the procedure, and parents and caregivers who are willing to allow the child to have the procedure, it's probably good in the short term to continue doing gastric aspirate and stool in parallel. And I believe this is, if not exactly aligned, it's concurrent with WHO's recommendation. But I do think that where gastric aspirate is not available, so for example, at a lower healthcare facility where there's not a trained provider, that stool should be prioritized. I think it will kind of depend country by country in terms of their current guidelines, their current algorithms, as to whether or not stool will ever actually replace gastric aspirate. I don't think we're there yet, because I think both are useful, and I think where we can do gastric aspirate, it should probably continue to remain part of the overall package of diagnostic testing. But I think the nice thing about stool is that it's a great option in places where those procedures cannot be performed. And with the increasing expansion and availability of expert, you now have expert machines closer to that point of care where the procedure may not be involved. And so I would say that would be, that would definitely, just from what I'm observing, be my takeaway, but I would love to hear from Winnie and Kwang on that as well.
Well, I agree with Charlotte that, you know, we still can use the gastric aspirate. Why we still need more evidence and experience on the stool. But stools show the convenience and also for the for the good during many different scenario, especially in the active case finding in the community. So the gastric aspirates can still do in the healthcare facility if we have like the proper technician and also a good condition for the healthcare facility, because you know that like not all the lower level healthcare facility can do that. Over to Winnie if you have any more addition for that.
Thank you. Yeah, just to add on, indeed, gastric aspirates should still remain one of priority specimens for testing in the lab for these children. But also with the coming of stool, of course, now it gives us the opportunity, at least for every child, to have a specimen to be tested in the lab. So we need to prioritize use of stool in settings where there is no pediatrician or properly trained staff to do the collection of these aspirates. But use of stool, again, should be prioritized in settings where we are not able to collect the gastric aspirate. So it should really be, algorithms should be all inclusive and place all specimen types a priority depending on the setting. Over.
Now this question is for Dr. Kong. Have you seen any trace call results from Expert Ultra? If so, how did you interpret?
Well, yes, we did see many cases for the trace call result because when we use the Expert Ultra, the sensitivity is much higher. So it means that it can detect like very you know, like small concentration of the bacteria. So the trace call result, when we see that in the field and also in the lab, we first you know, review everything and compare with symptoms if the clinician have described them, and also the in fact there are so many sites that they use the trace call result to treat the TB patient at first or second result. If we have enough time and the possibility to do the second test of the sample for the patient, you know, so we can repeat the test and to see if it's, you know, match with the first with the first result, and then we decide based on even like for the first or the second test of the ultra to put patient into the treatment. Thank you.
Now there is a question for Winnie. How have you addressed decontamination? Also, do you have any concern about cross-contamination?
Thank you. I'm not sure I understand what the first part of that question is referring to, the decontamination. The second part is more clear. So I will go ahead and tackle the second part. So we do not have any concern with regards to cross-contamination between specimens. Probably I'll take this opportunity to briefly describe the SOS method. So it's a one step where you aliquot part of the stool, about a gram, a scoop of stool, and place it directly into a sample reagent that comes with the gene expert, and it's well labeled. So it's just one step of transferring the specimen into the reagent, and after that, after incubation, the specimen is going into the cartridge. So that kind of procedure really eliminates chances of cross-contamination, just like it is for expert, even on sputum. chances are very minimal. And I wouldn't have any concerns about cross-contamination as long as the labeling of specimens and the sample reagent that you've put in, as well as the cartridge that you're transferring the specimen, is done correctly. There should be no concerns for cross-contamination. Over.
We are waiting for more questions.
Kayuri, may I just make a comment?
Yeah, sure, please.
I just wanted to, following on what Winnie said, I do think one of the things that's very interesting to keep an eye on is that our colleagues at KNCV who really pioneered the use of the SOS method have been doing quite a bit of research to kind of get into details like storage conditions. How long could you really allow the stool to be at room temperature, for example, or different types of transport modalities. And they really are doing a huge amount of research right now to really fine-tune the method and determine the different types of environmental conditions and whatnot that for which stool can remain viable as a specimen. So just I would encourage participants to sort of keep an eye on that research, keep an eye on the union conference, some journal articles coming out, because I think we're going to be hearing a lot more in the next 6 months to a year about just more about this method and the flexibilities in using it. Over.
And there is one more question I can see for Charlotte. Any difference in results for children with HIV?
That's a really good question. My understanding is no, that WHO recommends the use of this method in both children living with HIV and children not with HIV. Again, I hate to keep kicking it to Winnie and Kwong, but I know that particularly in Zambia, you probably do have a high number of children living with HIV who are being diagnosed. So I would also ask Winnie to comment on that as well. But my understanding is that the WHO recommendations do not differentiate between children living with HIV or children not living with HIV, that this diagnostic method is appropriate for both. Thanks.
Well, I have the same thought, and also, in fact, in our activity, we did detected like 2 cases, like add-on cases, and also not the children cases with, that they cannot produce the sputum. So for us, there is no different results for the children with HIV or add-on. If they can collect the stool sample and they cannot produce the sputum or cannot collect the other samples, so we can treat them as a sample that we have. So our experience and thought that we can use the SOS stool genesper testing for expansion of the sample collection, especially in the children and the people who cannot produce the sputum specimen, to increase the TB case notification in the community and also in the healthcare facility. So that's what our experience and the lesson learned in Vietnam. Thank you.
Thank you. So similarly for Zambia, we are really not advising use of stool for a particular population or category of children. We are using it both in children with HIV and children without HIV. In our validation, we did collect information on HIV status, but because we had very few children that were detected in the validation, it wasn't possible to really make a distinction in terms of detection in the two categories. I think that would be an interesting evaluation to do going forward. But however, we are using it across the board, both in children living with HIV and children without HIV. Over.
We would like to hear one final thoughts from all of you panelists. I will start with Charlotte. Is it okay?
Sure. Thanks, Carrie, and thanks to everyone. I think this has been such a great session, and the questions have been really good. I think my final thought is just to reiterate that this is such a great innovation, and it's a really great option, I think, for increasing detection of TB among children. And at the same time, I think it's really important for us to think about the entire range of tools that we now have and really think, think critically about how we can improve both the clinical assessment of children and improve the use of chest X-ray so that we really have a full array of tools in our toolbox and are ready to use them as we continue, even as we continue to really support the scale up of stool-based diagnosis. Thanks.
Can we hear from you, Dr. Kong? Your final thoughts?
Thank you. So as I just mentioned, we are really happy to have a new technique to detect the TB in children, especially for the small children that do not have able to produce the sputum. So we keep suggesting and keep supporting NTP in country to expand this kind of technique and make sure that everything will be monitored and improve from time to time in order to increase the TB notification in children. Thank you. Back to you, Carrie.
Thank you very much. And will you provide us with your final thoughts, please?
Thank you. I do to echo other speakers. It's like this is another great opportunity to have all children being bacteriologically confirmed for tuberculosis using stool. So it's a really wonderful tool to be used, especially where healthcare services are at the lowest level, and also to help complement other tools that are already available. And I'm really excited for its implementation. Thank you.
Winnie, we would love to hear from you.
Thank you. Indeed, this was a very good opportunity for us to share our experiences, and we are excited as a country looking at our data and seeing that we are increasing on the proportion of children that are being bacteriologically confirmed. We are also increasing on the overall number of children that are being confirmed with TB or notified with TB. So we would really encourage other countries to really take this opportunity to introduce use of stool, as it is really an opportunity to increase bacteriological investigation of TB in children. And we can now have that opportunity to confirm drug-resistant TB in children as well, and be able to improve on treatment outcomes for childhood TB. Over. Thank you.
Thank you very much. Over to Moremo.
Thank you, Kiri. I thank you to our panel, and Dwele, Charlotte, Kung, Winnie. Thank you to our host and moderator today, Kiri. This has been an excellent conversation. We are so happy to be able to present this new technique for case detection in TB detection among children, and look forward to supporting and answering questions about how this method should be scaled up and adopted according to the WHO recommendations. I would like to thank our production team, William Corley, Tom Price, Ashley Avella. I'd like to thank USAID for their partnership, support, and collaboration. This is the first of a series of webinars that the IDDS project will be hosting, and we hope that you will be able to join us for future ones. As we said at the outset, this presentation has been recorded, and the recording will be made available to all registered registrants. Thank you all for being a part of this conversation. And I think I want to reiterate something that Charlotte said at the outset. Stool testing using expert is one of a toolkit that we should be using to increase and improve TB detection among children. This is something that we believe very strongly in terms of improving bacteriological confirmation, but it also needs to be complemented by clinical diagnosis, clinical presumption, and examination. So we are advocating for the use of stool as a rule-in test, but it is not it shouldn't be the only consideration when we look for tuberculosis in children. The UN high-level meeting goals are still very valid, and we hope to make a lot of progress on catching up with those over the course of this current year, and as we look to a review of those high-level meeting goals next year. Again, thank you all for your joining us today. Thank you to the panel for your thoughts and expertise, and we look forward to seeing you again. Have a good day, have a good evening, have a good week. Thank you.